in the room. Before we start, do we need to do a quick tech check?
Yes, so we've already, Michelle is the only board member online, so we checked with her. She can hear us, we can hear her. So just a reminder for everyone, you have the little mics in front of you. When you do speak, please press the button and make sure the light turns green, and that will just help project the audio for the rest of us. So other than that, our tech check is complete.
Excellent. Great. Well, welcome everyone to the June meeting of the Universal Healthcare Governance Board. Katie, would you mind doing introductions and with the roll call?
Absolutely. Today we are going to combine a get to know you question mixed with roll call. So I will call your name and you'll do just an intro question, icebreaker, and then I'll kind of go on the list from there. So the question today is, what was your first job? Think back. First job. And we're going to start with Helen Belanca.
Okay. Hi everyone, I'm Helen Belanca. My first job besides babysitting was my first paid job where I actually got a W-2 was working in a fruit market. But I was in charge of the deli, so I was slicing meat, which I was a budding vegetarian at the time. It was a bit traumatic, but it gave me good experience.
Chanwei Chi.
Well, depending on how to define first job, right after my college graduation, we have a mandatory military services. So that might be the first job, but it's mandatory. But then after I discharged from the mandatory military services, where I was applying for graduate school, I took a short-term first job that was a trade company. So I spent half a year working in a trade company while waiting for the result of graduate school application.
Debbie Diaz.
Hi everyone, Debbie Diaz, and my first job, paid job in high school was a cashier at a grocery store. It was a small local grocery store in Miami that doesn't exist anymore.
Amy Fellows.
Hi, this is Amy Fellows, and my first job after picking berries that didn't last very long was at a small like $15 clothing store.
Warren George.
Hi, I'm Warren George. My first job, well, I grew up in Tillamook, so it seemed natural that I milked, many thousands of cows.
And Cheryl Ramirez.
Hi, Cheryl Ramirez. My first job besides babysitting like Helen was working in a dietary department of a hospital, feeding the patients, the staff, and
Bruce texted me, he's on his way, but he'll be back.
Perfect. And then Michelle Glass.
Good morning, everyone. Michelle Glass, she, her pronouns. And aside from babysitting, my first job was a server in a retirement home in Medford. And I had that classic experience of dropping an entire platter of dishes and breaking the bowl and being in tears. But then I got better, so.
Thank you. And then Judy Richardson is unable to join us today.
Great. So since our last meeting, we've received 3 public comment documents that I want to acknowledge and thank you to members of the public who are listening in and contributing. Those 3 documents are posted on our website with our meeting materials. The first was from Chuck Sheketoff, forgive the pronunciation if I got that wrong. He was a member of the task force and he recommended a communications consulting firm for us to consider and asked us to specifically address the greed in the healthcare system. The second was from Charlie Swanson, who called out additional values and principles listed in 1089 for our consideration. And the third was from Don Klosterman, who submitted a list of principles used by some religious groups and offered the Faith Caucus at Healthcare for All Oregon as a resource for us. So thank you to the 3 of you and to the others who are listening in and engaging in our work. We really appreciate it. And keep your feedback coming. So quick agenda review. As you look over the agenda, you'll see there's a couple of areas where we're hoping to have some board action. We're gonna try to finalize our policies and procedures today, possibly approve our ED evaluation framework, our guiding principles, our work plan, and some draft charters. So really launching into it today, which I'm excited about. We'll have some time to discuss all those in case there are any questions or concerns. And we have a couple of presentations today about healthcare financing and other states' efforts toward getting a universal healthcare plan. So good meeting. First, we need to approve the minutes from our meeting. Has everyone had a chance to review the minutes? Does anyone have any questions, additions, corrections?
I move to approve.
Great, is there a second?
Second. All right, should I take a vote with minutes?
Yes, we
Okay,
need a roll.
perfect. Helen Malonka,
Yes.
Chenwei Chi,
Yes.
Debbie Diaz,
Yes.
Amy Fellows.
Yes.
Warren George.
Yes.
Michelle Glass,
Yes.
and Cheryl Ramirez.
Yes.
Great, motion passes. And at this point, I'll turn it over to Morgan for the executive director report.
Great, thank you, Helen. I just want to share some of the work that I've been doing since the last board meeting. It may come as no surprise, but a good portion of the work that I've been doing is working with the work group, the work plan development work group, and working on revisions to the work plan and continuing to have a good visual of the work plan and making sure that we're that I've added all of the comments, both written and those comments provided at the work group. And then also drafting charters, that will be one of the agenda items you'll be discussing today. You know, as that work has been progressing, foremost on my mind is making sure that we have the resources to support the work that's in the work plan. So I've been meeting with outside experts about, you know, how to staff the revenue portion, including a meeting with the Legislative Revenue Office and the Department of Revenue, and also thinking through other experts to bring in. Just as resource experts for the committees that you'll be considering. And then also working with the Oregon Health Authority on their timeline and process for hiring the 2 limited duration positions that will be coming on late summer, early fall. And then also working with the folks here at DCBS and developing my own understanding of the state procurement process and the best ways to think about what pieces of the work we want to go through those procurement process. So really a lot of focus on how to bring in additional resources to support the board and the committees that are forthcoming. And then, you know, because I'm new to state government and a new manager in state government, there are also required trainings that I have to do here to make sure that we're following all of the guidance around good manager training. So I have a weekly 4-hour manager training that I'm going through through the Department of Administrative Services and their Chief Human Resources Office. That is really fun and is kind of like separate from the work of the Universal Health Plan, but is also great opportunity for me to develop my own skills and knowledge in support of the board's work. So those are some of the big buckets of work that I've been doing.
I just want to call out what an enormous task it has been for Morgan and the rest of the staff to wrangle all of our ideas about the work plan and try and get it in a coherent form and visuals. And so thank you for that. It's been a ton of work and I think it's a great product. So. Any questions about the executive director report? I think next on the agenda is last meeting, we had some additions to the our board's policies and procedures document. We approved the delegation document, but our general policies and procedures had a couple of additions. Morgan, would you go over those and we can decide if we're ready to approve them?
Yep, thank you. Yes, that's a great summary. At the last board meeting, you reviewed the general policies and procedures 01 and had a couple of additional pieces of feedback to provide that you'll see in the document and track changes. The first was in the consensus process and decisions and voting section. You wanted to make sure that there was language in there that allowed for votes in the minority, that those people voting in the minority would have an opportunity to share their perspective. So the language is, if there are votes in the minority, those members voting in the minority may submit an explanation of their vote and provide alternative proposals. So that is the new language at your recommendation. I reviewed that also with our legal counsel, Jake Gill, and that's ready for you to approve if you decide. The other piece was in the advisory technical committees and work groups section, where there was a recommendation to have explicit language in the policies and procedures to allow for non-board members to be on committees. So there's additional language there and some clarifying language that work groups are and work group expectations and differentiating work groups from committees. So the work groups will be expected to be short-term and consist of board members only as a venue for deeper discussion of the topics the board is discussing. So there's specific language that's been added that makes those separate from committees, and the committees would be open to non-board members. And those are the changes in this document from the last meeting.
Any questions about those changes?
Thank you for making the changes. I move we accept the policies and procedures.
Second.
Great, is there any discussion? Shall we vote to approve the general policies and procedures as they're written? Can we do a roll call vote?
Ellen Blanca,
Yes.
Chen Wei Chi,
Yes.
Debbie Diaz.
Yes.
Amy Fellows,
Yes.
Warren George,
Yes. Yes.
Michelle Glass,
Yes.
Bruce Goldberg,
Yes.
and Cheryl Ramirez.
Yes.
Thank you.
Great, so I assume Katie, we've noted in the minutes that Bruce Goldberg has arrived, and Bruce, we did a quick introduction, we all went around and said what our first job was.
So you should tell.
My first job was a busboy at the Jolly Fisherman Restaurant.
Great. Okay, next on our agenda is the executive director evaluation. Actually, it's a work group, I believe, the committee here, but with the work group technically. Since our last meeting, Bruce, Warren, and I met to discuss executive director expectations and sort of a list of things we wanted to use in terms of an evaluation. We shared that with Morgan. She didn't have any additions. The document that we came up with is listed in your meeting notes. And these expectations will be used for an annual review no later than February of 2025, which was about a year from her hire date. In addition, the three of us, Warren, Morgan, and I, will be having quarterly more informal check-ins, just to touch base about how things are going and give each other, all three of us, feedback about that. Are there any questions or feedback about the executive director evaluation criteria?
I move that we accept the valuation expectations as written.
That makes sense. Okay, great. Is there any discussion? Okay, Katie, can you do a roll call vote?
Ellen Blanca,
Yes.
Chen Wei Chi,
Yes.
Debbie Diaz.
Yes.
Amy Fellows,
Yes.
Warren George,
Yes.
Michelle Glass,
Yes.
Goldberg,
Yes.
and Cheryl Ramirez.
Yes.
Excellent. So next on our agenda, Warren has offered to do some background presentation on healthcare financing and the single parent model. I'll turn it over to you.
Okay. There is I don't want you to think that there's a conspiracy that the three of us who were on the task force always seem to sit together. That each of us, the three of us had a particular role to play. Bruce as chair brought a lot of history and skills and knowledge. Cheryl was assigned as the behavioral health representative and has consented next meeting to talk a little bit about what's going on in behavioral health. And looking forward to that. I was added to fill the role of fiscal management and change management representative. And I'll be talking just a little bit about the board's follow-up from the board presentation last month. And a little bit from my perspective of from that role about how the fiscal pieces tie together in a single payer plan. And not saying that there was full consensus, but this was a model that was kind of consistent with what the task force was working with. So next slide, please. At our, as I say, at our last governance board meeting, Bruce Goldberg led a presentation on the task force and the final recommendations. That task force recommended the single payer system formation of this governance board. My presentation is a brief follow-up of some of the financial aspects. During previous meetings of this governance board, I've heard different questions like, will Oregon health plans still exist? What's the status with Medicare and other questions? So I thought it might be helpful to just give a kind of a high level overview, talk about single payer plans and how the governance board looked at that. Next slide. Oh, you're ahead of me. Thank you. To help understand financial flows, we can start with a made-up hospital. Hospitals get their revenues from dozens, if not hundreds of different payers, because hospitals have to deal with many different payers, each with its own rules. There is lots of studies that show that hospitals spend as much as 20% of their costs on billing and dealing with payers. According to national averages, about half of their revenue comes from government programs such as Medicare and Medicaid. About half comes from private sources such as private insurance, co-pays, deductibles, other out-of-pocket payments. For seniors on Medicare, it used to be easily understood that Medicare was a government program and supplemental Medicare insurance was private insurance. Now Medicare Advantage blurs that distinction by using government money to pay for private insurance. Besides the complexity and high administrative cost of billing, there is another problem that affects providers and patients. The amount that hospitals get paid for each particular service varies according to who the patient is. On average, according to the task force actuarial study, if the hospital's average cost is $1 for a particular service, Medicare pays 81 cents on the dollar, Medicaid pays 69 cents on the dollar. And as reimbursements from Medicare and Medicaid have fallen relative to actual cost, the amount charged to private insurance has gradually risen to $1.37 on the dollar. This differential means there's incentive for providers to prefer higher paying private insurance patients. Some hospitals and other providers have closed because they have too many Medicare, Medicaid patients. They're very sensitive about trying to maintain a ratio between Medicare and Medicaid patients relative to the higher paying private insurance patients. The single payer system removes the administrative cost and complexity by replacing the many dozens of payers with just one unified payment system, which pays hospital $1 for $1 in services. Single payer combines revenue that would have gone to the government programs, Medicare, Medicaid, and money that would have gone into private premiums and out-of-pocket expenses, pays the hospital the same no matter who the patient is. because there is only one payer with one set of rules, it is easy to save quite a lot of administrative costs. The task force envisioned that hospitals could be paid on a global budget rather than getting paid for each individual service provided to each patient. Imagine the possibility of walking into a hospital without a billing department or a cash register, no bills for patients. Task force made a conservative estimate of the potential of 12 to 16% savings in the first year by simplifying the billing and eliminating middlemen. Total savings could be higher in later years. Because the reduction of cost and the elimination of patient billing, major cause of inequity in access would also be eliminated by eliminating differential pricing. But to achieve a single payer system depends on combining the different sources of revenue into one payer. So how realistic is that? Using Medicare funds in a state-run universal care program would presumably require special federal permissions. Because of the uncertainties of that permissions, the task force voted to let Medicare be inside or outside the system, depending on what was possible at the time, or to incorporate it at a later time when permissions were received. But this could leave out some of the ability to reduce complexity. We would lose some of the savings, and we would leave some of the inequitable access problems in place. There is more work to be done on this to fully understand how well a single payer system could work with or without, including Medicare. There's been new developments since the task force in 2024, and this is happening now. A new bill is being introduced in both the U.S. Senate and the U.S. House, making those what's called permissions easier to get, called the State-Based Universal Healthcare Act, or SABUCA. That new bill can make it easier to achieve a full single payer system, including Medicare. Waiver programs are already available where Oregon could request federal permissions to incorporate Medicaid funds into the same system. So Medicaid is expected not to be a difficult component to add. Medicare Advantage programs add complexity to including all Medicare recipients into a single payer system. One idea proposed by the task force was that for the state single payer system to act as a regional Medicare Advantage program in order to incorporate Medicare Advantage into a single payer system. The question of whether private medical insurance can be substantially replaced with a single payer system is a qualified maybe. There are different kinds of private insurance that cover medical expenses. There are private insurance policies purchased by individuals and small business in the form of actual direct insurance. There's also the medical portion of liability insurance, such as home, auto, and workman's compensation. There is medical coverage provided by so-called self-insured employers. There are a number of other private payers, including trust funds put in place by unions or past employers. Private insurance policies would be easily incorporated into a state single payer system because the state has the legal authority to regulate insurance. Likewise, the medical portion of liability insurance could be included in a single payer system, but the task force did not assume that liability insurance would be included, at least not immediately. Most large employers are self-insured, meaning that they pay for medical care directly or through a third-party administrator. The Employee Retirement Securities Act of 1974, or ERISA, and related court cases have held that states may not regulate self-insured medical payments as insurance. With federal laws making it so that states cannot force self-insured employers into a state single-player system, task force listened to legal experts, came up with potential funding structure under which all or nearly all self-insured employers would voluntarily want to discontinue their own programs in favor of the single payer system. Other sources of private payment are a small percentage of the total. The task force left that to be figured out later, by which that might mean us. And deal with that. Out-of-pocket costs can be easily decided by a single payer system, determining which services will be covered by reducing or eliminating cost sharing, including co-pays and deductibles. So the state can have a lot of control over out-of-pocket by according to their plan design. Designing a new revenue structure is difficult. The task force did not come up with a payment system it was willing to recommend. So this work is still to be completed by the governance board. Much of the financing work of the governance board will be continuing the work of the task force. How many of the existing fragmented components of healthcare will we be able to combine in order to effectively reduce the current high cost, eliminate complexity, and eliminate access inequity? So I hope that if there's any questions, I hope that at least creates an environment where we can talk about what we mean by a single payer. And single payer isn't the only thing that we can do, but it was what the task force recommended. Cheryl.
I do have a question. I just don't recall. Did we as a task force decide to exclude the VA and TRICARE from the single payer structure as a closed system?
Yes, there was not a lot of talk about that, but the CBZ Optimus in their calculation assumed that the people, particularly the people in the VA and IHS, would keep getting the services that they have. Those people would still be able, because they're residents of Oregon, be able to have other options in addition to the one that they already have. But it was kind of assumed that if you're covered by the VA and you have a history there, that you would want to keep going to the VA. So, and it was assumed that the funding for those systems, like the VA and the IHS, would continue as they are. You mentioned the word TRICARE, and I know less about that. But the idea was still to capture that money and fold it. My understanding is that people on TRICARE do get their healthcare locally. It's not a program that provides them already provides them care. So that would be part of the single payer.
It's a health plan for active duty and their families. So I'll say more about this next month, but the behavioral health system pays for services or provides services for veterans and active duty military that aren't covered by the VA or TRICARE through state general funds, county general funds, and Medicaid too. Medicaid does supplement, was that the right word?
And I did I don't want to use too strong a word, but I reviewed the language that's in the Sabuka bill at the federal level and ask for language to be included in that makes sure that the VA is contributing if people are using services outside the VA system, that the state can recoup that from the federal government. Bruce?
No, just to point out, I think Cheryl's question illustrates the fact that the task force talked about things very well. And that there's a lot of granular decisions that need to get made. And that's gonna be our work. That I wouldn't want us to think that a lot of these decisions have already been made. There were some things that just were avoided. Where does safe go? The issues that Cheryl raised, I think there's just a myriad of granular details, which is gonna be our responsibility.
And to add to that, much of this was based on like 2019 data and before. The world has changed a little bit, and we have to kind of review some of the decisions that we made then, and be sure that we would still make the same decision. Amy?
I just wanted to clarify for people on the Zoom, when you said IHS, you meant Indian Health Services, right?
Could you say again, please?
When you said IHS, you meant Indian Health Services. I just want to clarify for the people on the Zoom, with the acronym IHS.
Yes,
Indian Health Services.
assuming that funding would continue.
Yeah.
As it is, but that we would be providing more services, that they would be eligible for the state services. Thank you, Michelle.
Thank you, Warren. This is helpful. I guess I'm wondering, are you making it, is there a distinction being made between the financing and what is covered, the services covered? Because if my memory serves, at our last board meeting presentation, there was a statement made that people on OHP current Medicaid clients would retain the same covered services, but that the universal health plan was envisioned to mostly be modeled on what PERS recipients get in terms of services covered. And so that led me to think that OHP would remain as it is, separate in some way. But it sounds like on the financing side, it's envisioned to be part of the universal plan. So can you help me? Am I interpreting that correctly?
Yeah, I think there was kind of a couple of questions there. The answer to the first question is there's actually some of the people on OHP get certain benefits that wouldn't necessarily be as good in the med plan. And that could include dental, for instance. So it may be, and this is one of our tasks, is to figure out how to align with other agencies. It could be that most services would be covered under the single payer system, but it might be, I mean, the idea is for no one to lose benefits that they already have. So using dental as an example, it could be that everybody gets a kind of an average slate of dental care, but there would be an entity of OHP that continues to pay a higher level of dental care to the people who are eligible for that.
The big benefit, overwhelmingly, the biggest benefit is long-term care, which Medicaid recipients are entitled to.
Yes, and the task force, because of the large cost of long-term health services and the difficulties of that, the task force voted fairly early to leave that out of its deliberations of concern, it would be it would bog down the rest of the process. We're not held by that restriction. We look at long-term care. And that is an example of something, as Bruce says, that people on Medicaid are eligible for, but no one else is. Either on Medicare or unless you have private long-term care insurance. You pay those costs yourself. Does that cover what you were wanting, Michelle?
Yeah, thank you.
So Warren or anyone else in the room, do you have any information on the status of this SWUCA legislation in Congress? Is there energy behind it, or do you know anything about it?
Thus far, it is, there's numerous sponsors, both in the House and the Senate. It tends to not be bipartisan. Yeah, which would be one of the things that would help, but there are some Republican senators who are interested in sponsoring it. The discussion is just now beginning. Senator Bob Berkey of Massachusetts is introducing it into the Senate, and hearings are scheduled. That's about all I know directly. And you know, I expect that will not be a fast, a fast thing. But it is kind of a hope that the details of that will get worked out in the time frame, you know, that we're talking about in 2026 or something. There might be hope of that that legislation, which would that legislation would help with Medicare. Medicaid is already waivers available that would try to address the RISA Act, although it's not clear exactly how it would do that, but the intent is there. And the other thing is there are concerns that, well, in Oregon, particularly concerning if we decide that we want to remove the tie between employment and availability of healthcare. We run into some IRS obstacles that say there's certain things that might, well, let's say if employers pay less healthcare but pay more wages, pay higher wages, for instance, that could have a very adverse effect because people, as it is, if an employer pays for healthcare, it's not regarded as income under IRS. So that provides an extreme benefit to the employee. So what I've asked to be added to that bill is to maintain the tax consequences for any state that wants to do a single payer system, to maintain the tax exclusion no matter who pays the bill or pays the tax. That is not in the bill, but the sponsors have that and are considering how to add that to the bill. So it looks like my 10 minutes are up.
Does anyone else have questions for Warren? Again? Okay. Our next presentation is from Jenny Donovan. She's going to be talking to us about what other states have been working on in pursuit of universal health plans.
Good morning, everyone. So yes, as Helen said, I'm Jenny Donovan. I am Jenny Donovan. I am the Senior Policy Analyst for the Universal Health Plan Governance Board. And I have put together a overview for a multi-state comparison of what's been happening sort of in the country around single payer and universal healthcare systems. So next slide, Katie. So looking at Y-state comparison, right now, we have California, Oregon, and Washington working actively on universal healthcare plans. Vermont, we've included because Vermont in the country is sort of seen as the originator. It was the first state to actually pass legislation to enact a single payer system. It's kind of become, I think, a cautionary tale for a lot of people in how single payer universal healthcare is looked at. We included it here because it does have that sort of foundational idea. Next slide, Kate.
I just suggest, not for today, but that we also look at Maryland.
Sure.
I mean, Maryland has done one of the more interesting things, and apropos of Warren's presentation, I mean, they pay a single rate for hospital care. And I think looking both at how they did that and how they got that authority would be very important for this group, because they use certain authorities to be able to pay a single rate for hospital care, for Medicare, Medicaid, private insurance, et cetera. I think that's really an important piece of what we're doing.
Thank you for that, Bruce. So looking at what we compared, I think that the presentation that Warren just gave really informs a lot of the comparison components that we put together for this presentation, in that this kind of gives an overview to the board of how states have handled this question. And generally, these questions aren't settled for most states either, the states that are looking at it currently. And the way that Vermont handled it is included in the presentation to show sort of how that played out for them in terms of the decisions that they made. I do want to invite members of the task force as we go through the presentation to provide any context on Oregon, because I think that'll be incredibly useful as we look at some of the other states. All of the information that I'm providing in the comparison is either from enacting legislation that was recently passed or something that's akin to the task force report that's been done in each state. So we'll look at what the legislation was, what eligibility decisions were made, benefits decisions, cost sharing, governance. And when I say governance, I mean what would govern the system, not in terms of administration and how they would roll out and how they would do the payer system. Estimated cost and financing. Go ahead, Katie. And so looking at enacting legislation, Vermont was the first state, as I said, and they passed their legislation in 2011. They did not have a convening group that came before the legislation. They did request a paper done by Dr. I'm going to say South. I couldn't find a pronunciation of his name. I hope that's correct. Dr. South and some other experts in policy and health policy and economics from Harvard University. And they used that paper as sort of a backbone for what they started to look at when they started creating their single payer system. In California, they, in 2018, provided funding to a group called Healthy California for All Commission to study what it would look like and take to create a universal healthcare system in California. That resulted in legislation in 2023, SB 770, which don't get confused, we're also 770 for our task force, SB 770, which directs California within their healthcare department, not within an external board or external commission, to look at how to propose a plan for a waiver. They're supposed to look at financing, they're supposed to look at policy and legislative language that they'd like to have enacted, but the ultimate goal is what will the waiver language be when they submit to the federal government. In Washington, in the 1920 session, they created a universal healthcare group, similar to the time that we were creating our task force, doing similar work to our task force. That resulted in them putting together a universal healthcare commission, which is written to legislation as a permanent board. That universal healthcare commission has the authority to take a look at all different types of healthcare reform. And the really interesting piece of information about that legislation is that it allows any state agency with the authority to enact any of their recommendations, short of creating a single payer system. I'll talk a little bit more about that when we talk about some of the benefits and plans. And as all of you know, in Oregon, Senate Bill 770 created the task force in 2019, which has brought you all here today as a result of Senate Bill 1089. Go ahead. In terms of eligibility. So in eligibility, all of the states that I looked at included all residents. The only state that had a real exception was looking at Vermont, which excluded TRICARE and Medicare recipients, which Cheryl had just brought up with Warren a few minutes ago. That's a question that has come up almost in every scenario that I've looked at for each of the states that hasn't had really a final answer. I know here in Oregon, we've said that those with Medicaid would be covered to the fullest extent allowable by law. And that goes back to what Warren was talking about a little bit earlier. It's hard at this point to understand how we will incorporate Medicare recipients into the plan. And that will be a decision that the board has to sort of grapple with to determine how we can either bring in that funding or bring in those individuals who are currently covered by Medicare. But California, Washington, and Oregon all included all citizens in the state regardless of their federal immigration status. Vermont, at the time that they passed their legislation, was grappling with the question and were not sure how they were going to handle whether or not they could include those without federal immigration status in their plans. You can go ahead, Pete. In terms of benefits, every state has suggested both within any sort of task force or work group that benefits be comprehensive. The outliers are usually, will dental be included and will long-term care be included? Initially, when Vermont put forward their plan, there was no dental included, there was no vision or dental for adults, and there was no long-term care included. California, in its recommendations, sought to include long-term care, and in the enacting legislation, the legislation requires that long-term care is included. The interesting thing there that we'll see when we take a look at financing and cost sharing, or I'm sorry, the cost of the plan, is that looking at long-term care for California actually increases the price to a higher level for their first year than any of the other plans that we're looking at. Usually you see a cost savings in your first year. They do anticipate that that cost will go down over a 9-year period was the period that they looked at, but it was the only one to include long-term care, even though they anticipated a first-year increase in cost.
Do you have any info about what that coverage looked like? Was there a limit on coverage in terms of dollars, time? Or was it similar to the Medicaid package, which is, you know, in essence, an unlimited benefit as needed?
I don't.
That'd be
but I
really
will look
helpful
into
to
it.
understand.
Thanks, Bruce. That's a great question. And then in terms of Washington, again, essential benefits, dental and long-term care for Medicaid recipients. Washington is a little bit interesting in terms of my reviewing their information in that they are currently working. They're currently in a similar position to us, even though their board started, I think, about a year before ours did. Their commission, I'm sorry, they're not called a board. Started about a year before we did. They're still working through a lot of the information and their recommendations as well. So a little bit of the information that I'm getting, and this was desk-based research. So I haven't had a lot of opportunity to reach out to different people in different states and have good conversations. I will also say that oddly, a lot of the information from Vermont is no longer available, at least that I can find. I don't know if it's part of our firewall, but a lot of the documentation from the groups, I haven't been able to access. The report from Dr. Sao is available and the legislation itself is available. And of course, in Oregon, as we were just talking about, comprehensive coverage based on what PED beneficiaries get currently, and includes dental, increased funding for for behavioral health. I haven't seen in other states behavioral health being called out as explicitly as our task force called out. And so it's not as clear to me at this point if that's something that they're really grappling with or that they're really looking at enhancing benefits for. But I can say in Oregon, it's something that has been called out both in the task force and with the governance board. And as we were just talking about, long-term care was not included in the original task force recommendation, but it is not something that is prohibited to the board to look at. In terms of cost sharing, so Vermont, when they were looking at their plan, didn't actually begin the modeling for their financial system until 2 years after the legislation was passed. They were supposed to submit a plan for financing in 2013. When they started looking at the numbers, it seems as though it came to a pretty big surprise that the cost of the plan would be as high as it was. And what they were looking at was very, very small cost sharing. 94% of actuarial value of the insurance would be covered. And so it was anticipated that residents would pay a very, very small 6% of their healthcare coverage. That does not include the taxes for the financing model that they were looking at. California, Washington, and Oregon have all said there will be no cost sharing, at least in the plans that they're looking at and the recommendations that were made. Can you go to the next slide? In terms of governance, Vermont was the only state that I've looked at that suggested there be a public-private relationship to the governance of how the health plan would run. In Dr. Sal's paper, they talk pretty extensively about why they recommended this dual public-private relationship. It had to do with efficiency. It, in their opinion, would include increased competition, which would drive better efficiencies and lower costs. It also gave some of the business interests and the private insurance companies more buy-in to want to support the program in their perspective in the paper that they put together for Vermont. In California, it has, their legislation currently is silent on whether or not they should have what type of governance board or oversight. And that's something that they're still supposed to be looking at as they're working on their 770, on 770. Washington also is undetermined at this point. The commission that was put together, though it was written into legislation as a continuing commission, it is not at this point seen as the oversight for the universal health plan. It is part of their work to determine what the governance structure should be for the universal health plan in the state. And here in Oregon, the task force recommended a nonprofit public corporation with a board that reports to the legislature and governor. This board was a part of that recommendation, though the task force did see the board as being a paid board that was more of a permanent representative board to the universal health plan. Looking at financing. As I said, Vermont didn't start really looking at financing until 2 years after they had started their program. At that point, they had really decided what they wanted to be part of the universal health plan, who they wanted to cover. And as they started putting together the financing models, they couldn't get the money to come together and to even out at the level of coverage they wanted to provide to their citizens without an 11.5 payroll tax and a 9.5 adjusted income tax. The revenue that they would have seen from that tax base was 151% increase in total state taxes. At the time that this was passed, and we'll see this on the next slide, the total budget of the state of Vermont was just over $5 billion. So this program was anticipated at the point that they did their calculations to cost $4.3 billion. So the governor's office, who had campaigned on universal health care, who had brought forward the legislation and worked to get it passed, suddenly saw this enormous amount of tax increase that they would have to bring forward. And that was essentially when Vermont's single payer system started to collapse. They found the proposed tax revenue to be untenable and politically infeasible. In California, they've looked at a few different plans in terms of how they would like to finance the plan, but none of them have been finalized. None of them have gone into legislation. So the finance plan was created in a report that was put together by the Healthy California for All Commission, which was akin to our task force. They put together a financing model that recommended a sliding scale progressive tax based on income. They also recommended the state seek federal waivers and repurpose the current health system expenditures. And so trying to put together a full pot based on a few different outlying pots that were created. That wasn't taken into the legislation and the current work of the healthcare system within the state of California, because it wasn't handed over to a board, because it was kept with the state agency, is to revisit those calculations, revisit that financing model, and determine if that really is how the state should look to move forward with their financing. In Washington, they haven't proposed a financing structure yet from the commission. It's part of their work to look at finance. However, Washington, their work group did create 3 models to look at how a plan could be financed. And most of the difference in the models has to do with how the plan would be administered. So they created models A, B, and C. Models A and B are for universal models. Plan C, interestingly, is not about a universal model. Plan C was to look at how the state could cover immigrants who were without documentation, how the state could bring those into the system. And as the commission started to look at that, they actually adopted Plan C. And because of that component in the legislation that allows any agency that has the ability to do, the authority to do so, to enact anything that the commission recommends, they've actually started working on that. And it's very akin to Healthier Oregon, which OHA talked about the last time they were here. So Plan A had the state administering all of the funding that would go out and all of the universal healthcare plan. It would make a premium for taxes to go into the model, but individuals would be exempted in the premium if this plan were to be administered the way that they look at in Plan A. Plan B had health carriers administering the plan, and costs a little bit higher than Plan A with the state government administering the entire plan. Work group members were surveyed to see which plan they would like to see brought forth, and a majority of them very much supported Plan A. There were actually several members who abstained from the vote, however, saying that they weren't really ready to vote for either plan. And as we know, in Oregon, we had a recommendation from the task force for a payroll tax, a healthcare income tax on households with income above a 200% poverty level. But again, as Warren and Bruce had pointed out, that wasn't adopted by the task force, and that is part of the work of the board to make that determination financing.
It wasn't very different from Vermont's levels. And different, but not substantially. Within the same ballpark.
And looking at estimated costs based on population. So in Vermont, as I was saying earlier, the cost for the plan was anticipated to be 4.3 billion. And I do want to point out that some of the estimates were based on plan years. So Vermont was looking at these calculations in about 2012, but they were basing it on 2017 numbers. The population estimates that I used are not the same numbers that they would have been using at the time. We now have actual population counts from that time, and so the numbers are probably skewed just a little bit from what they were looking at when they were creating these. And so based on a population of 626,299 people, and interestingly in Vermont, their population has not increased to the level that they anticipated, it's actually gone down. But based on that, their per capita spending was estimated to be $6,869 per person. So just under $7,000 per person for healthcare spending in Vermont, based on this plan. But like I said, looking at I think it was $5.01 billion budget for the state at the time, the $4.3 billion price tag really proved to be something that they did not feel comfortable moving forward with and bringing to the people of Vermont. In California, they are looking at an estimated cost of $527 billion. And that's based on a plan that has no cost sharing and direct payment to providers and expanding long-term services. So they had a couple different scenarios to look at in California. They chose the one that included no cost sharing, direct payment to providers, and expanding long-term care and services, which, as I said earlier, upped their cost anticipation and increased costs the first year over current spending by about $10 billion. But they anticipated that they would see that amount go down and that they would see cost savings over the 9-year period that they examined. That led to a per capita cost in California of $13,493 per person. Looking at Washington, again, they had Plan A and Plan B. So as I said, Plan A, which was administered by the state, had a slightly lower cost than Plan B, which was expected to be administered by healthcare providers. Looking at their per capita cost for Plan A was $7,791, and Plan B was $8,007. So not a huge difference in the two plans in Washington. In Oregon, the anticipated cost was $54.62 billion in the first year. That was a cost savings. And the per capita cost there would have been about $12,318. None of these plans, California, Washington, or Oregon, the estimated costs were based on what the work groups or commissions looked at, or in our case, what the task forces looked at. And as Warren mentioned, most of these calculations and estimations were done prior to the pandemic, and the values may not still hold quite as well post-pandemic. Yeah, sure.
I'm curious about why Washington's estimate is not like way higher than Oregon's, given the population, but so is it because the benefit package isn't as good? Or is it just the years that they're estimating? You know,
It could be
22
based on
versus
plan years.
26?
Because Oregon is looking forward to 2026 and Washington's estimations were based on 2022 figures. I can look deeper into that. That's a guess on my part. I'm not sure that that would be why.
Jenny,
Yes.
I just, I think these numbers are super interesting. I don't know if you don't mind me interrupting, but I'm just pointing out that like Vermont estimated their cost per capita at $6,869. Plus they had a 6% cost sharing. And 11.5% payroll tax and like 9-ish% income tax. And the conclusion they came to was that was just financially way not feasible, that financially that was never gonna hold water in their state. And our estimated cost per person are $12,318, not including long-term support services, with roughly the same, payroll taxes and income taxes and no cost sharing. So we're almost double where.
I think it's $2017 versus
That was
2026.
Yes.
Yeah,
So
oh, yeah,
that's
that's,
That's not a real appropriate
yeah,
Yeah.
okay.
comparison.
And this is definitely information as we move forward with the governance board, as we look at cost estimates and financing. That, as I was saying, we're gonna have to really look at updated numbers in terms of
Okay.
what equals out in each area. For Vermont, that cost estimate was incredibly high at that time. And I think looking at what the Oregon per capita, what would be looking at towards 2026 is probably, I think we would see if we asked someone to calculate the numbers for Vermont now, probably,
Okay,
we would see
Yeah, that makes
a
sense.
closer.
So did you just for the per capita cost divide
I did,
the 4.3 billion by the population? So the numbers are for each of those each
each population with each
years.
estimate in the years that they were estimated, absolutely.
Yeah, so not a real apples to apples.
yeah. it's-
Right, no.
Okay, yeah.
And finally, for takeaways. So I think it's important as we look at Vermont, and Vermont, as I said at the beginning, is sort of presented as a cautionary tale and what other systems can look at in terms of what to do and what not to do when looking at universal care. However, the Green Mountain Board, which was created as part of the legislation for the single payer tax system in Vermont, has continued to work and continues to this day, and continues to look at health reforms within the state at an incremental rate. And so though they didn't achieve single payer, they have been able to continue to look at ways to innovate in the state as they move forward. In California, they made the decision to include long-term care in both in the recommendations that were made and in the legislation that was passed. The legislation stipulates that long-term care should be included. And it increases the cost, absolutely. But it also increases the magnitude of what the change would be both for the citizens of the state and looking at universal care, what the recipient, also the recipients of that long-term care. And so looking forward, as we take a look as a board at whether or not we'll include or not include things, there's always a cost benefit analysis to look at. And look at how much something might increase cost, but what the magnitude of that change might be. And finally, looking at the Western Seaboard, Oregon, Washington, and California are the states working most ardently on long-term care at this, or I'm sorry, on universal care at this point in time. We've had some great conversations with some representatives from California about their plans, and they're very interested in what Oregon is doing. I'm reaching out to Washington to see if we can have some conversations with members of their commission to compare and contrast some of the decisions that we're looking at, both from our task force and what we're looking at as a board. And so we're really very much sandwiched within the hub of activity for universal care at this point. And I think that as we move forward, it'll be a real opportunity for us to look both to California and the waiver work that they're doing, and Washington and the work that they'll be doing with a similar population and a similar plan to see what their costs and financing models might look like. And finally, I included with the presentations, the resources, so each of the each of the legislation that was passed by each state to enact it, and their group's task force, whether it was a task force, work group, or commission, what their recommendations were in the reports that they created.
I wanted to ask kind of how are we, in terms of the scope of this, defining long-term care? Because in disability services, ODDS, there is a service category of long-term care that has nothing to do with like seniors living in nursing homes or getting in-home nursing and support services. But even if somebody is disabled and living in community with family, they sometimes still get that service category. I think the Medicaid dollars are involved in that as well, but I just wanted to kind of clarify how we're defining that.
Thank you, Amy. So all of the information that I saw from the reports that I looked at, I think long-term care was defined as those who were aging. I don't know if it included, but we can take a deeper look into that and see if they were including disability services as well.
And just to add on to that, it's also what determines eligibility. Just because you're on Medicaid doesn't mean you get long-term care.
Yes.
You have to be deemed eligible based on your inability to care for activities of daily living or a variety of things that make you eligible to receive that benefit. So it's the benefit itself. It's also what criteria there are to get eligibility to that. And also great presentation, Jen. That's really informative.
And like I said at the beginning, oh, I'm sorry, please, Dr. Chi.
I just want to supplement both Bruce and Amy's comment. The reason there's a might be confusion about definition of long-term care is arbitrary because in the commercial private health insurance, generally they have a limit on that cap of how many days of hospitalization are they covered. Right. And beyond that is considered long-term care. So we have one option to address that. If we do not want to include the elderly long-term care, as long as we don't set a limit on hospitalization, then we address the non-elderly long-term care portion. Otherwise, we have to define what is long-term care.
And the final thing that I was going to say is, as I said at the beginning, this is mostly desk-based research, and there were some really great questions that came up. And this will be something with the information set that we'll be refining over time as we talk to California and Washington more. As we get more information and the work group continues to work, keeping this comparison in mind, I think will be useful. And continuing to ask these sort of questions to differentiate will be something that I continue to take a look at. And so if we ever want to revisit a comparison or we want to revisit some of these topics, that's something that I'm happy to do. Sure.
Are there other states getting ready? I imagine there are. I'd like to hear about other states who are just about to launch. And also I thought Massachusetts was also out front too.
So I did not do any research on Massachusetts, on Maryland, or on Colorado, which is another state that comes up fairly often in looking at universal or single payer healthcare programs. I am not at this point aware of other states outside of those that have been looking at programs, but that's definitely something that I'll be moving to look into now that I've sort of looked at the ones that we know are close to us, working currently in Vermont, which, like I said at the beginning, is sort of the one that everyone goes back to as the first state who actually got the legislation passed. Everyone sort of comes back and looks at Vermont again, but I'd be happy to look both for other states that might just be starting to look at this type of work, and also looking at Colorado, Maryland, and Massachusetts, because they're not necessarily universal or single payer systems, but they've done innovative things.
Very good.
And Amy, did you have another question?
My question was about Massachusetts.
Warren.
Thank you, Jenny, and I agree with Bruce that there's few oranges in with the apples. Some of those numbers, every one of those numbers means something as long as we understand just what it includes and what it doesn't and the time frame it was meant for. I have a comment, you brought it up relative to Vermont and, you know, just a tax not being viable or, and I think that is mostly a matter of public perception. I mean, one of the things that we have to understand, it surprised me when the first time I thought about it, actually, state government is like this big, healthcare is like this big. And so anything we do with healthcare is going to be bigger than the state government. Doesn't mean that it's run through the state government's books. And it just means that we're trying to guide that into a healthier plan. And so, you know, when people talk about, you know, spending what seems like very large amounts of money, and most people don't understand in America that we're paying $13,000 per person because you don't see it. It's coming, you know, out of your paycheck or it's coming from your employer. And so we're just not aware that that big amount of money is being spent. But the single payer system, you know, has potential to lower those costs. So we might say, oh, you know, Oregon will be paying twice as much the size of the state budget, but we'll, you know, saving billions of dollars. So, you know, I think that's something that that you have to recognize the costs that you're not paying, as well as the new costs that you're paying, and that's as much of a public perception problem as is reality. And I suppose what Vermont found out that it's a public perception problem is a political problem, and it's reality. But I'm hopeful that with people with public understanding that we can get support, and in fact I'll plug the poll that I commissioned with another Republican business person back in 2019, said 62% of people in Oregon would pay a public tax 2 to 3 times the size of state government in order to have a universal plan that no co-pays, everybody gets covered. And, you know, so I think that support is there, if we can just capture that.
Just a quick information, the professor who advised Vermont, his name is Bill Shaw. And he was my advisor.
And he was a consultant on our task force.
And
Great guy.
he also was instrumental in designing and planning Taiwan's universal healthcare when I was still a graduate student. And then he also advised several European countries, including Macedonia, to develop their single payer system. And he wrote a lot of very helpful article. I will dig out and then share with the board in terms of how to have a systematic view and review of a national health system. So I will share that reference.
It was also very interesting, and Dr. Xiao, thank you so much. I tried to put it in so that somebody would give me a pronunciation and could not get it to work, so I appreciate that very much. In their paper that they created for Vermont, it was the only paper that I read where they actually incorporated what the political perspective might be in terms of looking at the system and how they were bringing the system in and how to integrate more of the business interests and more of the private insurer interests to try to build support around the universal healthcare system as they started to create the program. And it was very well documented in that paper to say, looking at these political considerations, this is how we advise that you move forward. And I thought that was really interesting in the paper.
And I should also give another professor a credit, the late Professor Wu Reinhardt, together with Bill Xiao, they were both instrumental in helping design Taiwan's universal healthcare and continue to advise them. And I highly recommend the board member to read Professor Reinhardt's last book, Price Out, has a fantastic analysis of the US healthcare system and problems.
What's the title again?
Price Out,
Priced out.
yeah, by Professor Wu Reinhardt.
Any other questions? Thank you.
Thanks so much, Jenny. I really appreciate that.
Actually, can I just make one comment?
Yeah.
I just want to make a comment to Michelle's point earlier about the difference between benefits being financed and who's eligible for them, et cetera. You know, there's another piece to that, which is how it's administered. And just so we all understand, when it comes to our long-term care benefit in Medicaid, it's actually administered very differently than medical benefit. The medical benefit is administered through the CCOs, but the long-term care benefit is administered by the Department of Human Services. So I just bring that up to point out it can or cannot be administered in the same way. There's a lot of different design choices.
Yeah, I had two thoughts. I just kind of want to underscore what both Warren and Jenny brought up, which is, and Dr. Chi, because there's a piece where we need to figure out the financing piece, and then it's about bringing the community along too. So like, you kind of have to do both. You kind of have to understand what the political situation is, what the businesses are prioritizing, and doing both of those together would really point us towards success much more effectively. And then the other thought I had, Jenny and I were sort of struck at the West Coast sort of energy around universal healthcare plan, and sort of briefly entertained the idea of like, what if we did a regional universal healthcare plan? And then we thought, we can't all get on the same page with daylight savings time. Like, we haven't solved daylight savings time on the West Coast, so like putting us all together to do that, I think would be a very big challenge, but it is interesting to think about sort of a regional effort, maybe at the very least around federal legislation around Saluka. I don't know if there'd be energy, make that happen. Okay, yes.
Just a quick request, since we are all on a first name basis, please don't call me Dr. Ju, just call me Junwei or Jun.
Okay, okay, great. Okay, we're gonna take a break now, and we will reconvene at 10:30, and start up again.
Sounds good.
Yeah.
10% this year.
The first order of business and the second part of our meeting here is going to be going over the recommendations from the work group that was working on our values and principles. So I'll turn it over to Warren for this section of the agenda.
Oh, thank you, Helen. I served along with a number of you on this group to review values and principles. And before I start, I will say that a lot of what we came up with is, I mean, we listened to excellent presentation last meeting by Junwei. And that really kind of helped us to move quickly into discussions about ethical frameworks. And so I really want to acknowledge that. So our work group, and by the way, I'm reporting for the work group as the group facilitator. And the other people who were there, you know, certainly will have the chance to say, to add or correct as we move through this. We prepared a document which was in your packet of discussion and recommendations. And we actually started with the general recommendation that we as a board adopt the Health Equity Commission's statement on health equity. And I'm hoping that you've all had a chance to read that. And toward the end of this presentation, we will have a chance to decide to vote to see if we want to adopt that as our own statement. So beyond that, we came up with, we started with three overarching principles: maximizing health, fair distribution of medical resources, and minimize poverty. We had a problem with the word poverty and how we measure that, or you know, we can't minimize all poverty, but poverty are we. So we tried to change the definition of that. And since the group last met, we didn't have agreed to this yet, but the idea to minimize financial hardship on individual patients due to medical billing. As we reviewed these, we realized that we wanted to add a fourth overarching principle about community, the role of the community in, among other things, in owning the system, the feeling of ownership being, I think, very important. I think we all recognize that unless the community feels like they own the system, it's not going to survive very long. But community ownership and governance. And toward the end of the presentation, we'll have a chance to we'll just do a consensus whether we as a group agree with these four overarching principles, none of which violate any of the language in SB 1089, but it can enhance our understanding and our drive to action. Next slide. Looking at, Cheryl.
The only suggestion I might add is, instead of saying individual patients, that has a certain connotation, like only for the medical part of the field, really. Also, I don't think the financial hardship is necessarily on individuals only, it's on their families. So I'd rather see something like minimize financial hardship on individuals and families. That's how I see it, because sometimes you're talking about, you know, minors or people, or, you know, dependents who are reliant on, you know, their parents, for example.
And that
That's how I
was,
would feel it.
yes, and in the group, that was an interesting part of the discussion. Where do you draw the line? You know, if someone has to quit their job to take care of you, that's a financial hardship. You know, but where do we kind of stay within the medical realm? Because that's our scope. John,
Yes, I agree with Cheryl that it should go beyond individual patient, including family. But when during our work group discussion, we also face what Laura mentioned. How to restrict our responsibility strictly to healthcare related, because we cannot address the non-healthcare related financial hardship. And so the question is, how do we fine tune the language so it is explicitly healthcare related? Because we, universal healthcare cannot address other financial hardship, it has to be healthcare related.
Yeah, I completely agree with Cheryl's statement, but, and so I want to underscore too what she said too about replacing the word patients with individuals, first of all, because patients are mentioned several places in this document. And we should refer to them, I think, as individuals instead of patients, just for that reason. But, and yes, and within the scope of our work, minimizing financial hardship on individuals and their families related to healthcare costs. You know what I mean? We could just say something like minimize the financial hardship attributable to the healthcare costs on individuals and their families, because, you know, still finances, medical bills, medical debt is still the number one cause of bankruptcy. And if we just did that, it would be an enormous
And just to supplement, the reason we have to be specific, because for example, in UK and some other countries, universal healthcare, they do cover lost wages, which I don't think we will cover.
Oh, that's really good one.
And I think the patient word is important too, because in mental health, they're usually referred to as clients, not
Yes, that's right.
patients. So,
And
and
yeah.
there can be immense financial hardships from trying to get mental health services.
we could minimize medical financial hardship on individuals and families. Might be,
And somewhere have a definition of what all is included, that we're including under medical
or healthcare.
Healthcare,
Good
yeah.
idea.
Yeah, healthcare, the
healthcare.
financial hardship on individuals.
yeah, thank you for that discussion. Now looking at those individually. If you're going to maximize health, you have to decide what that means. And we considered, and it's in the document, that if we're going to measure something, the role of the individual to be well informed and make their own decisions is a very important aspect of a successful maximizing health. The role of let's say government to choose a measure like life expectancy or something is kind of a different thing. I mean, you're looking at the satisfaction of the individual patients, but you're also looking for some population measures. And we looked at several, including life expectancy, quality adjusted life years, disability adjusted life years, and other measures. And we realized very quickly, among other things, thanks to Amy, that some of those measures have been declared invalid. So Amy, would you like to say just a word about that?
I don't remember this number off the top of my head, but it's specifically to quality or quality adjusted life years that there was a bill passed last session. You know, that board is no longer allowed to use that, and so it's important that as we look at some kind of population-based measurement tools, that we don't replace that with something that is also discriminatory against people with chronic health conditions, disability, people of color, et cetera, which quality was determined to be discriminatory.
So, you're saying that quality is very subjective and that someone might judge another person's life as having less quality because they are in some way, not equally able. Is that the basis that the,
Yeah, Disability Rights Oregon tried to get quality removed for the last 20 years.
yes, certainly.
I just want to have a quick comment on the issue of quality. The quality is very legitimate measurement. Many countries use that, especially UK was the first country to develop the full table of all conditions quality. The problem in Oregon was, if you remember during the 1989 to 92, when the OHP was trying to do the prioritized list, the initial study they commissioned using quality table, not developed in Oregon. I think they used that from Sweden or Norway or other countries. That itself is problematic because quality is a subjective measurement. Each society needs to develop their own quality. So the problem with Oregon using quality was primarily we were using other countries' quality. If we conduct that survey, it will be Oregonians' value. And that will be very different, but we haven't done that. So that is part of the problem.
I agree, and whatever country it was a very homogeneous country, which is one of the issues, but also I'm not sure that Oregon is any less ableist or racist than other places. So I think it's something that we'll have to really dig into and get advisement from different communities that are most at risk to be discriminated against with whatever measure we come up with.
And compared with quality, the more popular DALI is even more discriminatory. Because the DALI that used by WHO, by USAID, and by Gates Foundation, they simply measure the disability, and that's more explicitly discriminatory, whereas quality measures the overall quality of life. So that's not specific discriminatory against disability, it's just measuring how people feel of the overall quality of life.
Something that we added, when we're looking at individual fulfillment, there are times, I think we would agree, when the interests of the community are strong enough that they can take precedent over the individual. And as example would be a community action against the contagion that has if community action can prevent widespread harm. Any comment about that? The next slide. Oh, come on.
There's something the board need to further consider is about population measured in terms of maximizing health. Because when we get to more detail, and we can take lesson we learned from the Oregon prioritized list, because eventually we will have to face, we cannot cover unlimited benefit. So which benefit to cover eventually we have to base on some objective criteria as well as public value, because the important lesson learned from the OHP prioritized list was to set the healthcare priority is not a scientific or technical issue. It's a political value issue. And I have some in-depth understanding because from 1999 to 2001, I was invited by two Japanese universities. They were funded by the Japanese Ministry of Health and Welfare to specifically study Oregon's priority setting. So in that 2 years' time, I also need them to visit the OHP and those leading persons who were involved in the prioritized list. And so the main conclusion, and also Oregon set the example, both in the policy world as well as in academic world, is to show the world prioritizing healthcare is not a technical issue, it's a political issue. Because After that initial prioritized list, based on cost utility analysis, there's a lot of objections. And so the commission went through first iterative, have the town hall meeting in almost every county to collect public value. And based on that public value, they move around those prioritized lists and publish it, still lots of common criticism. Then they held second iterative, again, took the whole year to go to every county to do the town hall meeting. And then they readjusted. So by the time we actually implement the prioritized list, it's hard to tell to what extent the original cost utility analysis matters. Because, so that shows the world the prioritized list is not a technical issue because it determines who gets to treat or who get to live, who die. And there is no scientific or objective way to guide us when it comes to life and death. It's all about public value. And so my recommendation is for the eventual population health measures, we need to have a more systematic, because the way the OHP did was not very systematic. They didn't detail how, based on how they measure those public input to move around the prioritized list. But we need to do something more systematic, how we gather public value preferences in terms of priority.
Thank you, Chairman. Alan,
Can I add one more thing? So in terms of maximizing health, in addition to individual fulfillment, good population measures taking, into consideration the comments about how we measure that. Community action against contagion, which I think is public health priorities, is what that's meant to address. I would add in terms of maximizing health, attempts to minimize the harms from healthcare, because healthcare is responsible for harming folks too, and having measures that look at the quality of healthcare and appropriate utilization and minimizing the harms of healthcare is part of maximizing health.
yes, thank you. Bruce,
Can someone just talk a little bit about what individual fulfillment means?
well, I'll speak for myself in the discussion that we had. I mean, it's kind of based around the right of the patient to make their own decisions without obstacles. So it's the right to be informed, but the ultimate decision on healthcare should lie with the individual patient, and there shouldn't be obstacles to them reaching their full potential.
That sounds really good, just that's really different than I read individual fulfillment.
Well, we had to find two words.
Autonomy.
Yeah,
When we, in our discussions, it sounded a lot like shared decision making.
Okay, got it.
Yeah, but also needs to be balanced by minimizing harms, because sometimes what people want from their healthcare could potentially cause harm. Right, so minimizing that. Michelle, you have your hand up?
Thank you. Yes, I just to add to what my colleagues have already shared about this particular piece. I believe that one of the things we discussed was that a key measure that we wanted to use in evaluating how things were going was patient satisfaction. So it was part of this larger conversation about autonomy within healthcare as a foundation of health equity, and then also how we measure success being really about how satisfied people on this universal plan felt with their coverage and care.
excellent, thank you. I might add that the population measure is actually one of the things that's spelled out in SB 1089 is that we have to adopt measures consistent with other stakeholders and things relevant to healthcare, so that that is eventually we don't necessarily need to decide them, but certainly making these things ready for operation, we have to understand what those measures will be. Next slide, please. Oh, the fair distribution of medical resources. Actually, we discovered is quite complex. We could ask different people what fairness is. And do you allocate your resources according to who will benefit most? Or who needs it most? Or do you give the same effort for all patients? How do you do that? And in deciding that, we decided there's really should be some questions for the community to be involved in determining those values and principles. I made the comment in the group to say, and sometimes we go to the extremes to have these discussions, but if there was like one heart and it either goes to me as a 75-year-old or to my grandchild, you know, if we're equally, I would certainly want the resources to go to the younger generation. But it was pointed out by Michelle that not all cultures would look at that question. You know, the value and experience of senior population is part of the culture. And so we talked about things like how do you get community input on these questions. If you use a poll surveying, that's one way to do it. But one technique that's been tried at least in other countries and in the US on other subjects is the concept of a citizen jury, where you get enough people to represent the full population, and you present the issues to them, and they make decisions based on reaching consensus and being sure that they've included satisfaction for all parties, including minorities or other present. Joey, can you tell us a little bit more about citizen juries and where they worked and how that could work in Oregon?
Yes, and actually in the US, EPA has done a lot of citizen jury. So citizen jury work like a trial jury. The idea is when we try to solicit public values, the public method is survey, but survey has major limitation in several dimensions. One is you're surveying individual people, and individual people, at least two constraints. One, they may not have adequate information to make their choice, particularly if choice is complex. Two, in a survey method, it is called methodological individualism, meaning individual responding to the question as an individual. But citizen jury try to address those problems. Citizen jury is also called the methodological communitarianism, meaning the member in the selected jury, they have to first listen to expert commentary, particularly on a complex issue. They have to be informed about those complex issues, and then they went on deliberation. And the idea of deliberation is ideally people representing different perspective, different value. They will have different opinion about the decision. The idea is try to reach a consensus. And so when in a citizen jury, when they are deliberating, they are not deliberating as an individual. They're deliberating thinking they are member of the society, of the community. But also they get to hear the different opinion, and not just different opinion, but in the deliberation, people pose different opinion, have to explain why am I holding this. And so the idea is eventually either reach a full consensus or near consensus. And so that has been a method used. South Korea probably is the first country to use that in a national scale. And one of my PhD students used that method as a dissertation. Rebecca Shum, who is also the board member in the CO.
And she used that in Taiwan, using Taiwan's national health insurance to try to ask people difficult questions about how to set priority in terms of benefits. And so those methods, I found out that US EPA has done that extensively in the community, but not so extensive in healthcare or public health.
And you talked about that being using nationally. I could see in Oregon, there's in the urban areas may have different concerns than rural areas. So, you know, if we were going to use it like that, we'd have to figure out how many different groups that we need. Helen?
Yeah, I mean, this is obviously a huge and fascinating topic. The thing that comes up for me when I see this is, you know, where hospitals are located in the state. You know, there are some things about fair distribution of medical resources that we may or may not have control over, because where, you know, sometimes access to healthcare has to do with if there's a clinic in town, or if there's a hospital in town, or where's the nearest emergency room, where's the nearest trauma center. We're not building a health system from ground up where we could design those things. We're starting with a lot of infrastructure already in place, much of which is not fairly distributed around our state. And so I think it's gonna be really interesting to consider, this is a really important principle, and to consider that there's some pieces that we don't necessarily have control over either.
Okay, we do have other items on our agenda today, so I'm gonna move through this quickly. The minimizing financial hardship, by whatever title we choose to give that, of course, involves spreading out the cost of significant illness and injury societally. And the ability to pay should be considered. Of course, we want to reduce the risk of high cost events. We want to reduce complexity, improve transparency. And financial stress really does kill people. And I'm aware of suicides and things just because of people getting bills that they couldn't read, couldn't handle. And that is, to me, whether we call that a medical issue or a financial hardship issue, it's something that we need to address. Next slide. Community ownership is something we really need to talk more about, that includes things like financial hardship. Are we being efficient with the community funds that we have? Are we being fair in governance? And what are the things that we can do to be sure that it is the sense of community ownership is there? Next slide. So ultimately, we have to, in order to make these, to operationalize these principles, we need to look at each one of these and say, where are we failing? Where can we improve? And of course, that's needs to guide us in our actions. Based on the time, I would suggest that we next meeting, we vote on the endorsement of the health equity statement. And we can talk a little bit more about these four principles.
So the issue on the table is whether or not we should adopt and endorse the health equity statement.
I'm just saying, we're out of time on the agenda.
Got it, yeah. And then the second thing is whether or not these principles are should be the principles that guide our work, understanding that the details of each would need to be worked out. I think the decision is, do we feel ready to sort of adopt that now, or do we need some more time and have the work group convene a little bit more to flesh some of these out and then bring them back at the next meeting for adoption?
I'd say bring them back.
Yeah.
And can I just make a comment about the equity piece? Amy had sent around something about targeted universalism, which I really think is something for us to consider and to think about including that in the equity statement. I'm assuming that's why you sent it around.
Yeah. Just to give us another lens.
Yeah,
of
which is-
when we're talking about this.
And thank you for that.
Is the work group planning to still continue meeting or what is the status?
I think we can discuss that later and let people know. It's a very good group. I'd be very pleased to see it continue, but we need to have some specific destinations to set up for that.
Okay. So we will table that for now, yes.
Yes, I agree with Warren that, before we can decide to continue the work group, I think I suggest that we first decide maybe on next meeting whether we approve this, because once approved, we need more work in operationalizing. So that will be the next stage of the work group, but before that, I think it's important for the board to decide whether we are gonna adopt this. That will be the next meeting.
Right, that these are the overarching principles and then what then operationalizing happens, right, that's what I was getting at too, like, is this enough in terms of overarching principles to adopt now to do more work on? Yeah, Michelle, you had something to say?
One of the other next steps we had discussed at our last work group meeting, I think it was the last one, or maybe the one before, was just, again, if we got a signal from the whole board that this was heading in the right direction, we had talked about defining each term, which I think will be necessary. There's no way to wordsmith our way to clarity. I think we're just going to have to create some definitions. But again, I think to the points that my colleagues are making, we would need to have a strong signal from you all about whether this is the right direction or if we're missing something important before doing that level of work, at least in my mind.
Yeah, thanks for that. What is the feeling of the board? Is this, we can do a fist of five of showing your support or not, on is this in general the right direction we would like this work group to go in, and not missing anything critical. If you agree with that, let's show what becomes for a fist of five. Yeah, fives, fours, and Michelle. Fives, okay, so yes, so we can tell the work group, you're on the right track. These principles are, we all agree with these, we're gonna consider some more input on the targeted universalism and sort of creating some definitions, and then come back at next meeting and review this once again. So, thank you. Okay, moving on to the work plan. This is sort of a large piece that we can get to. Morgan, can you walk us through it?
Happy to. Thanks. Well, just first, as we all know, having a work plan for the next 2.5 years of the governance board's work is essential. It is a plan to meet the deliverables that are outlined in 1089 as a minimum. And, through the conversations, I think there are additional pieces of important work that have been called out in the work plan draft. In addition, staff, including myself, will use this work plan as a guide to resource the work. The structure that you all choose to provide the work, will work to get experts, bring in consultants, and make sure that we are supporting the board's work. So it is an important document to provide that guidance for our future work. So before I go into the specifics of the work plan, I just want to thank the work group members. There were 2 meetings of the work group where there was feedback, direction, identification of missing pieces, and this document is a better product given the work group's work. Next slide. So just a little bit about the process and a reminder of where we have come since the May board meeting. In May, the governance board established a work group to review a staff developed work plan and to develop one charter for a finance committee to get that work going. I think in light of the presentation that Jenny provided on how important the finance and revenue work is of this, I think there was a call out of the board at the May meeting to try and get that work started as soon as possible. There's a draft developed. Staff will work with the chair and the vice chair and the Oregon Health Authority staff to develop a work plan framework to meet those deliverables. And then the work group met twice to review and give feedback. Like I mentioned, I think a couple of the big pieces we'll go through were identifying some really big missing pieces in the work plan that was developed. Also, the feedback was definitely to start all of the work sooner than was originally proposed by staff. I had proposed kind of staggering the work or kind of having sequential work one and then the other, and overwhelmingly the work group wanted to start it sooner on most fronts. And you know, because of starting the committee sooner, there was staff work to develop draft charters for all of the committees, not just one. And so that will be part of our conversation today in talking about the committee charters. Next slide. So this is a summary of the feedback. This is not all of the feedback. There were opportunities to give verbal feedback at the 2 work group meetings. There was opportunities to provide edits outside of the work group. But a high level summary of the work group feedback was to restructure the work plan to lead with the community engagement and communications first. As I mentioned, the work group identified missing bodies of work, including communications and specific call out of that important transition planning. And new work streams were added to the plan to reflect those 2 pieces. We expanded the community engagement work stream to include more listening, but more listening really using existing feedback that has already been provided either in the joint task force work or in other areas where communities are providing feedback about health, like community health assessments or in community health improvement plans. And then identify the gaps that need additional very specific outreach. In particular, at our last work group meeting, we talked about behavioral health and behavioral health providers, reaching out to disability-led organizations, and making sure that those were called out in there at a minimum, not only. And as I mentioned, the work group recommended starting all of the work sooner than was originally proposed. So this is a visual just kind of in the 3 major phases of the work. At our last 2 meetings, we've talked about this kind of building the Universal Health Plan Governance Board Foundation presentations like you heard this morning, like Bruce provided at the last meeting around the task force recommendations, the task force recommendation for financing that Warren gave, what's happening in other states, really to build your knowledge and understanding of the work that's come before. And then very quickly moving into the phase 2, which is proposal development, and that the bulk of the time in the next year and a half will be spent on proposal development. And then I am proposing that the phase 3, the final report, start in January of 26. I think that's also trying to build in a little extra wiggle room to finish the recommendations and really bring the final proposal development work to completion in the early January to March, but also to do a lot of that presenting on the recommendations as we're kind of completing the final report. And then before you, thank you. And then you'll also see in the oval circles, the status reports to the legislature in December of 24, December of 25, and the final report due to the legislature and the governor's office in September of 26. Next slide. So this is a kind of closer look at the timeline for phase 2 and 3 of the work plan. You'll see the 6 work streams that are called out in here: the community engagement and communications, the finance and revenue, the plan design and expenditures and operations. And you'll see this the proposed timeline is to start community engagement and finance and revenue kind of as soon as possible. and lead with those two work streams, and then very quickly to phase in the other work streams. You'll see the transition plan timeline expanded from the last iteration that the work group saw. The feedback was that we needed more time for that transition planning. So that timeline has been extended, but it's still assuming that we need to figure out some of the operations of the plan before to start to that transition. So it starts a little bit, it allows for the operations work to start sooner and then the transition planning. And then you'll also see the phase 3, that final report. And there's, you'll see, as I just mentioned, a little bit of the overlap of the community engagement and communications into 2026 to allow more sharing of the work that the governance board has been doing in the development of the universal health plan. Next slide, please. So here's a visual that we developed on the 6 work streams. I think it's important to note that this is not one and then the other and then the other, like the timeline just showed. These are just columns kind of outlining the very specific deliverables that each work stream will be responsible for. In addition, we've called out the expertise that would be needed to support that work stream. As I mentioned, a lot of what I'll be doing and have been thinking about is how to bring in experts, how to bring contractors, and how to support the work beyond the staff that we currently have. But then you'll also see we need staff support for each of the committees so that there would be kind of a universal health plan governance board staff member assigned to it, and that there will be additional support and for the research and policy work from the Oregon Health Authority policy analysts. And then another important thing to note is while there are 6 work streams, this is still proposing 4 committees to try and help manage the work. So there's communications and community engagement is in the Community Engagement Committee. The Finance and Revenue is in the Finance Committee. The Plan Design and Expenditure is in the Plan Design and Expenditure Committee. And then Operations and Transition Planning are both in the Operations Committee. Next slide, please. So, questions for you all. Are there any questions for me? Yes.
I had the opportunity to look through the work streams in more detail after our work group meeting. I just had a few thoughts. So with the finance and revenue work stream committee, I was thinking, and we talked about this a little bit earlier, I think an important deliverable would be, besides the financing strategy for the universal health plan, to show the contrast to the currently funded healthcare system, like show the puts and takes. To me, it'd be important to show that some expenses will go up, like the tax, but the high deductibles and out-of-pocket costs won't exist side by side. I just think that's a really important piece for this committee, is it called a committee or work group, to work out for the communications group. I just think that's gonna be really. So that's one thing. In the communications, you mentioned, we're starting with listening sessions, but we'll use existing reports and things for that. But it seems like it should be added to the deliverables that we're going to do these listening sessions, and maybe we will need to engage with a few other groups, like we mentioned. I was wondering about unions too, as one constituent group too, but I don't know if maybe we want to focus on them. And then in operations, I feel like it to be included in the assessment would be workforce needs to stand up that nonprofit. I know we talked about IT, see there. That was called out, but I think workforce would be really important for that new body. And then last in transition, and this might just be my lack of understanding of how the universal health plan would get formally approved. and have statutory authority. Would that be through legislation necessarily, a ballot measure, a mixture of both, or do we not know that? I just wanted to know. Because it talks about how this will transition to an actual, new healthcare system. But I think it'd be important to understand how that will be officially done, officially approved. Those are my thoughts. Thanks.
Well, the work of the governance board is to submit a plan to the legislature and the governor's office. And so I think the recommendations are for what statutory authorities need to exist for the public corporation, for the public trust, for all of those pieces. So that would be incorporated into the plan that goes to the legislature. And then I think Bruce, correct me if I got this wrong, but I think the recommendation was that in that plan, they have to see how this would transition. How would we go from one plan to the other? So there needs to be thinking through that to include in the plan to the legislature so that they could say like, oh, if we pass these laws, this is how this could actually be feasible.
We did have workforce in here at some point. Where'd it go?
Yeah, we definitely had workforce. I think it was not in a deliverable, it was in more of the tasks that were associated it. And it was added to plan, design, and expenditures. In addition to
It seems right.
it was added to two places. It was in one in the original version, and this was a recommendation that was given in the work group. So added it to one of the other work streams, not in the deliverable, but in a task. So
Yeah, so it would be considered one of the tasks, but in the deliverable for plan design and expenditure, we should say something. It should say final recommendations on universal health plan benefits, eligibility, provider reimbursements, workforce needs, and cost containment strategies. I would put it explicitly in there because it is going to be an enormous lift, and calling it out somewhere is key. Of course, there's a piece of it in operations, but we think of this plan design and expenditure group as the group that's thinking about how services go out. So finance and revenue roughly is thinking about how money comes in. Plan design expenditures, the group thinking about how services go out. And so understanding like how care would be delivered. And we thought workforce would land more there, whereas operations is more sort of the agency work and how things will be administered.
And I was talking about the workforce of the agency, the new agency.
Oh, yes.
Like we're talking about IT needs. To
Right.
me, it would be important to include what workers need
Yes.
to do that.
Exactly. So yes, IT and new agency workforce to
Right.
process claims and all of that.
Yes.
Yes, that's fully in operations. And that is more called out in the tasks.
yeah, and I don't actually think that was called out. So that's a good catch. Thank you.
Awesome. What other questions, feedback?
Relative to the question of are we ready to approve the work plan? At this level, with what we've seen so far, I think this is something we can work with. I think at the deeper level, in the task lists that accompanied this, I think those were, this is a very big task putting this all together. I think there's more thinking about what should be in those task lists. And so I think there's work that needs to be done on that, but I can support the basic framework that's been put up in these specific slides. And I note that there's a little line on the previous slide that talks about the board lead and to be determined. And so we need some volunteers, obviously, to take those different tasks.
So yeah, so I can comment on sort of the process of how we imagine this going, but does anyone have any specific questions about the work plans so far as Morgan laid out?
I think Bruce had a question.
Yeah,
I had a comment.
yes,
I think this is great, happy to support it with one very large caveat that I'd like some assurance about. That this is an iterative document
yes.
and that there will be a lot of issues that will come up. And I would hate to see anyone say, well, sorry, we didn't include that in our work plan. I think there's more unknowns than knowns here.
Right.
And we need to be open to this, so whether we call this a draft, a framework, this isn't the comprehensive look at the work.
Yes.
So that was one thing. The other piece was just in terms of the operations and the transition group. One, the expertise required for the operations group. I think there needs to be, apropos of this discussion, that IT, business administration, health plan, this is gonna be running a $60 billion organization, and this is having this be state government admin structure just isn't how I see this. We're not creating a state agency, we're actually creating something different and need to have a huge array of business and operational acumen, not simply state agency acumen. And I would say the same thing about the transition group. I think that's got to include consumers, it's got to include health care providers, it's got to include health plan organizations. I think the issues come up about what happens to not only what new workforce we need, but what workforce may now no longer exist that we need. And I just think the expertise envisioned in those two groups is off. And I think it needs to have a different flavor. This is not policy, and this is really operations and transition planning, which is really different.
Right, so that's kind of the process that I was alluding to, that this is really a rough framework, and how we envision this going is. If the board is in agreement, that we kind of have this as a starting place. And as kind of a general idea of where we're going and kind of the general buckets of work that needs to happen. And then what we imagine is that we'll be eventually creating 4 committees. It might be a little staggered in terms of when they launch, but 4 committees, operations, finance, plan design, expenditures, and community engagement. And that there will be, we're hoping at a minimum, 2 board members from all of you on each of those committees, with one of you agreeing to be the lead or chair of that committee, and the liaison back to this broader board. The first task is, so we all had enthusiastic agreement that we don't have the expertise we need to implement this work plan on this board. And so we are going to be inviting non-board members onto these committees to supplement our expertise and help us out. But what we're imagining is that the board members who agree to be on these committees would first meet just among themselves, whoever they are, the 2 or 3 people or more on each committee, and review the deliverables, the expertise that they feel that they're gonna need, and the charters for the committees to flesh them out a little bit more, get a little bit more detailed about what's needed there, and then bring that back to the board. So that would be your first task. Once that's done and there's some agreement on the level of expertise that's needed to complete these tasks, then we will post an invitation to the public, and we'll hopefully target and recruit some folks that as well to join us in this work, and then submit applications. And then the committees themselves, as well as the staff and the rest of the board, will have an opportunity to help select who's going to be on them. So yes, there's definitely more work to be done. What we wanted to put in front of you is sort of a framework, and like, this is kind of the buckets we think need to happen. But yes, there'll need to be a little bit more development. Is that process clear? Is that how it is? Okay. Okay, good. Any other questions or comment? Yeah, Amy.
This might be a little bit in the weeds, but just by thinking about it, when you mentioned in the first category, using some existing reports and data like CHIPS and CHAWS, and Michelle probably or maybe already brought this up, but I believe the Regional Health Equity Coalitions do some kind of regular cycle of needs assessments. And in my experience, when I worked with the Lane and Douglas one, or Rise of the on Willamette Valleys is their name, on their process of, because they're a newer one. And I've been involved in tip and child work. Very, very different questions were asked and outcomes through the Regional Health Equity Coalition. I recommend that we also tap into whatever the most, current version of those that exist are.
Any other questions, clarifications? Yeah.
I just want to, Bruce said it very eloquently. But I think this has to be a living document that's driven by the board as we go. But it's a really good start to get things in bins and so we can begin talking about it, and even more importantly, begin doing.
Right. Excellent. Anything else? Is the board ready to approve today? You think we wanna?
Well, I think that there were some really great suggestions made, so maybe with the caveat, there are the couple of caveats, that it's a
Yeah.
living document, but it's a guiding. And if you're ready to approve with the suggestions, I think around, especially around the expertise, around and call out of the workforce and I captured some of those recommendations that felt really important to add
Yeah.
to this version.
And Cheryl's deliverable around compared to the current system.
Would we be able to show consensus, maybe because it's still a working document, if you're a little uncomfortable taking an official vote. But I think, for me, if we could all show consensus that we're in the right direction, that we have something that.
Yep, whatever, however you would like to do that.
Okay,
It's to you.
okay, all right, let's do a fist of five around the room about if you were going in the right direction here. Oh, we got 5, 5, 5, 4, 5, 5, 5, and Michelle is 5. Excellent, yay. Okay, great, so this is our working document for our work plan. And as I mentioned, this will help us launch these committees. The first two that need to launch are the finance and the community engagement committees, but the other two are quick on their heels, so to speak. So operations and plan design and expenditure. And so what I'm hoping, should we do the charters first maybe, or should we do the, see if there's anybody, let's do this, see if anybody, board members would be willing to be on the committees first.
Okay.
Let's look at the charters.
Yeah.
I'm looking at my notes. Let's look at the charters. So cause that'll help for everyone to decide and pick where you'd like to spend your time. So go ahead, let's look at the charters.
Sure, so in the last work group meeting, there was conversation about the work group charters that would need to help move kind of the theory into, what the committee would be doing. Right now, each of the committee charters includes the tasks and deliverables from the work plan, some process considerations, some timeline and meeting frequency, some subject matter expertise, resource needed, and staff assigned to the committee. So what's been happening just in terms of process, there's the big, larger narrative document. When the work group has made changes to that document, I've made changes to the visual and then changes to the committee charter. So as this process goes to make sure that the documents are aligned, the recommendations that you just made, I will make to these charters to reflect the alignment between the documents. I just want to say that so that as you're thinking about that. In the work group, there is a lot of discussion about the committee membership. The discussion was that each committee should have a range of board members and non-board members from 6 to 10, that the perspective and expertise was more important than a specific number, and that there was a desire to have them be larger rather than smaller, and a little bit of concern noted that if they were too small, would they have the expertise that they needed to be on those committees?
I saw this in the slide. I have been, looking at some of the more finance groups have been looking a little smaller. If you've ever been in a room with 10 economists, it might not fit with building codes. So I think the group should have some flexibility in that, rather than having a fixed number. But I agree with, there are many of the committees where larger will help and be part of that sense of community ownership.
Thank you. And there was discussion about maximizing opportunities for the committees to meet and have people participating, including evening and weekend meetings, should be options. And looking at innovative ways to collect feedback or to have discussions. And one of the pieces that was discussed was that there should be a minimum of 2 board members for each committee. I think that would have some good cohesion between the board and the committees. And there was a little bit of discussion about what if 2 people didn't volunteer, and then it'll be up to the chair and the vice chair to have conversations.
Paul told us.
Right, there's a long tradition of being voluntold for this kind of work, but we're hoping not to get there.
And then I just wanted to go through a little bit about the timeline for committee recruitment.
Can I just add in one thing, Morgan?
Yes.
So of course, because of the public meetings laws, all these committee meetings will be public as well. And the public is welcome to listen in. We will be selecting people to be official members of the committee by an application process. But with all of these meetings, they will be publicly posted and available for anyone to listen in. And of course, we always welcome public comment to the meetings, yeah.
If I could make an additional clarification, there could be people who are in a committee that just because we don't add somebody to committee, there are resources in the community that we're likely to want to bring in and talk to, depending on, their expertise or the people they represent.
That's a very good point. And I think some of what I'm starting to look at are who are experts that we could bring in for a presentation or 2 for the committee, but might not be full-time committee members.
Yeah, I'm wondering about the selection process and like, is staff gonna propose based on other type, it seems like the selection process will be really important when we're asking for, maybe we'll get nobody who applies, but if we have more than the 6 to 10 slots or whatever,
Yeah.
it'll be important for us to have a selection process in place that's fair.
Yeah,
Or feels fair to the community.
So I think all the applications would come to the staff, but what I've asked for is that each committee would get a list of all the people who've applied. And then a recommendation from staff of who they would suggest we add, so you would get both. And you would see the full list of people who applied and then the committee and the board together would decide who's on.
Okay, I'm just curious about like a draft selection. How we decide. Like,
A
how we decide
criteria
part,
for who's
like,
gonna be on.
Yeah.
I think it's gonna be different
For each committee, yeah.
Yeah. And that's a good thing to think about. So when you're on a committee, that will be part of your task as sort of board
As the
members on
board.
that committee is trying to figure out what you need
Identify the
and how
selection
good stuff,
process.
yeah. Yes, Michelle.
I was just wondering if we are required to use the state portal for these applications. I know that's what we all went through, and I will say as a professional bureaucracy navigator, it was not a super accessible process. So I'm just curious if there's anything we can do to reduce barriers. I know it's a problem across the board for commissions and committees in Oregon, and it's something that some boards and commissions are looking at, but are we required to use that portal?
Oh, yeah,
I would vote that we use a simple system. Thank you, Michelle.
Yes, my understanding is that we don't need to use that system, that system is for kind of state appointed boards and commissions, and these are more operating committees of the board. So we're looking at having an easier application process that would be a form that would be posted online and available on our website and would come to staff to look at. So
And just could be emailed back, is that what you're suggesting? Like people could fill it out and then email it back?
it would be a form that
Yeah.
you would use, you would go to the website and you would fill it out. and then you would hit send and it would go to us. So it would be as easy as possible for people to apply. And yeah, so just a little bit about the application process. I will talk about that and then go into the timeline, but you'll see a little bit of language that I put on the slide, that the applications would come to staff, that we would do a review for expertise, regional and diverse representation on the committees, that the chair and the vice chair would work with the board liaisons to make a recommendation to the board. So there would be kind of multiple eyes on it, but that Helen has asked, and it makes sense that you have the whole list of people and that there's some staff work that's done in reviewing that list. And then you guys would make the decision, and at the August board meeting, you would approve committee membership. And just if there are any more questions about process, maybe I could run through at a very high level the timeline and the reason that's a August and not a July approval. So, first, you've already given a general consensus support for the work plan that establishes the 4 committees, but, if you were gonna approve the draft charters in draft, again, knowing that they will change based on those tasks and deliverables, we would also want to identify board liaisons at this meeting. We would develop recruitment materials and set up a website for that form and a process. We're currently working with the communications folks here. This timeline says a July 1st open recruitment. We probably won't be able to open that until the next week, given capacity. So everything in this timeline would move back a week, but we would still have the application process open for 3 weeks. And that would mean we would have a full 3 weeks that would not be around the July 4th holiday, where we would make that available. I hope that you would all send those to your networks, that there's some pushing out that staff does to get it to different communities throughout Oregon. We would do more of that kind of recruitment. Applications would be due July 26th. We would move that staff review and the board liaison work to the next week, because we have this additional follow-up if needed. We've already used that in this timeline, but we would still have those ready for our appointment at the August meeting. And during that time, I just would say staff would also be working on, some early plans for those committees as well, so that we would be doing the staff work behind the scenes while to get those committees ready and to support you on those committees.
Thanks. Interrupt here, we're just gonna see, is there any public comment? No public comment. Okay, great. Proceed on.
Yeah. So, any feedback on the committee recruitment process, timeline, application process?
Just think it's gonna be real important to cast a really wide net of interest. So I think it'd be really helpful just to let the board know who and how you're getting the word out to, so we can look at it and see if there are any gaps. I think that's gonna be the most important thing, is widely disseminating and gathering applicants.
Yes, we can put that on for the July agenda to talk about who we have done outreach with and who we've heard from, and make sure that we're not missing anyone by our July meeting before those applications are due. Yes.
I just have a quick clarifying question. Do committee member has to be in Oregon?
We had talked about that and we couldn't think of a reason why they needed to be. I think we can have folks from anywhere who are willing to participate. Does anyone have any concerns or objections about having non-Oregonian members on groups?
They bring expertise. That's what we want.
That's what we thought too. Yeah, excellent. Yeah, so anyone can be on. Anyone can apply.
And then we would look at like if there was a majority of non-Oregonians in one group, or things like that.
That would be really interesting.
That would- Probably not. Yep. Did Michelle have a question? Oh, I thought her hand was up.
Is there any other questions or comments on the committee charters or the committee recruitment process? Yes, sure.
I thought the charters were good, and I've been in a lot of groups with charters, and I think it would be important for us to have some guidance on the decision-making for the recommendations that are put forward by the particular committees, because, you know, we've run into problems with when there's consensus, that means like 100% agreement, and then nothing goes forward, because you can never get full 100% consensus, and maybe that's what we want, I don't know, but we need to be able to know if it's like just majority voting and through a recommendation, or if we just absolutely have to have all 6 to 10 people agree on it before making a recommendation to the board. I just feel like that's really the avenue of the charter.
And Bruce.
Yeah, just on the operations committee, kind of similar to my comments previously, I think that committee reads to me like a governance committee, not an operations committee. I don't think we have to really do a lot of review of public corporations. That's important, but we're actually setting up a complex healthcare organization. So having some of the tasks being review how complex health organizations work, having expertise from people that actually run complex health organizations and deal with IT systems. It just reads to me very much like this is about governance, and I don't think the operations group is about choosing a governance structure. I think it's about creating an operational framework for what's a $60 billion complex healthcare organization. And I just think we need to look at it and review it with a different lens.
And Michelle.
I just wanted to mention or suggest that if the rollout of the applications gets pushed back farther than anticipated, that the end date also get pushed back so that there's sufficient time for people to apply. I just don't want it to be so rushed that we miss out on some of the talent that we're looking for.
Especially since it's summer.
Right, right, yeah, and especially since it's summer too, so, yeah, so we will certainly be attentive to that, and we're, as you know, as we've mentioned a few times, there is sort of a little bit of a time pressure to get this work done, and on the other hand, we want to have the right people. We can also discuss, or the community members can discuss too, whether or not, I mean, the charters will be sort of a iterative document. And then we can discuss also whether the membership of the committee is also a sort of a rolling or a continuously updating process. So if the committee starts meeting, there's a few outside folks on there, and then you decide, oh, actually, we really need more expertise on this piece because we don't really understand it. If it's possible to invite people on when you're a year into the work, let's say, you know what I mean, so that it's not a one-time chance to be on the committee. I don't know about that. I think that makes it complicated in terms of staff, but I would say we at some point we will close the application for this first round, but then the committees can propose or request bringing somebody else on and then adding them at a later date too, so that we don't, like you said, inadvertently leave people out who could meaningfully contribute to the work. Very quiet.
I'm wondering, and I don't know if this creates too much work for staff or isn't necessary, but like, if we all sent, you know, staff kind of a list of kind of our first thought about like our networks that we would be sending these out to, and they compile a list and send it back out to us, just to kind of, it might help us brainstorm before the July meeting on who is missing. Before we, you know, I mean,
Yeah.
if that makes sense.
Yes, I'm really hoping that you all are really actively involved in the recruitment and especially sharing it with your networks. And if you send who you shared it out to us, I think that would be really helpful, because then we could identify gaps.
Yes.
You know, okay, well, we've got to some groups in this part of Oregon, but we haven't sent it to anyone in Salem, for example. So that would be really helpful. And we could do that before the applications go live. The great thing about knowing the timeline is that we can look at that recruitment process before the applications are live, and so we can get it out as soon as the application is live. It's a really good idea.
Warren?
I'm gonna piggyback off of what Cheryl said, and I think it's important that we know exactly the decision-making the process or things that we are giving to these committees. And I'd certainly say in my view, they don't really make decisions, they kind of bring back choices and rationale, so that they would probably be working on a consensus model and not on a voting model. That's my own thought, but I appreciate your comment, that we need to have specific instructions, so everybody understands of which rules we're operating.
Yes, and my question would be back to this group. Do you want to have that discussion about how the committees make decisions here? Or would you like to ask the work group to continue to work on that? Or we could use the model that Warren just suggested, or use the language from the policies and procedures and adapt it to committees, because the committees would be making recommendations to you all, not making independent decisions. So I think what I heard Cheryl say is if it's only consensus focused, are there recommendations coming to the board? And we want to make sure that there's a process to move from the committee to the board. So would you like to talk about that now in the 5 minutes, or would you like the work group to continue to look at decision-making for those committees?
The work plan work group?
The work plan work group. Yes, thank you for.
So there already is something in our policies that says that all committees of the board have to follow the general policies and procedures of the governance board as a whole. And we do have a decision-making process lined out in there, which is aiming towards consensus. But if there isn't consensus, allowing for minority opinions to express their views, using, sort of less formal voting, so taking votes on important decisions, and then using less formal voting strategies to try to build consensus. We could just say that's what we recommend that they do, or if there's an alternative to that, that might work better. We could have the work group discuss that a little bit more. I would propose having the work group go through it rather than doing it here if we want to do something different. So I think the choices are, do we want to just have them follow our decision-making process that's already outlined in our policies and procedures? Or do we want to have the work group kind of think that through a little bit more and put something more specific in the charters? Who thinks we should just have them follow what are already policies and procedures of this board? Raise your hand.
Good with that, so long as it's clear they're making recommendations, not decisions.
Oh, right, yes,
Yes,
of course,
yeah.
yes. making
I just think that needs to
recommendations,
That
be
needs to be
spelled out. I think that was
spelled out
Cheryl's-
in all the
Yeah.
charters, yeah.
Okay. Right. And then I just want to make sure, does anybody feel like this needs to be really fleshed out a little bit more clearly and have the work group work on this and bring it back? Raise your hand if you do.
I have a different question.
Yes.
So like, as part of the recruitment process, the charter would go with the, whatever they're gonna fill out as the application.
Yes.
So they get some clarity around, I'm not a decision maker before they
Yes.
apply, like I'm here in an advisory capacity.
Yes, we'll make sure that that's really explicit in there, that the purpose of this committee is to make recommendations to the board. And we're relying on people's expertise to make formal recommendations to the board, and then it'll be up to the board to decide to approve or not each of those recommendations.
Yes, and having the draft charters, I think, is helpful then, with all of the additions and suggestions that have been made. But somebody who's saying, I want to be on that committee would know a little bit
Yes.
about what the expectations of that committee would be.
Of the role.
Yeah, and I would add the suggestion around the decision-making process in that charter as a new
Mhm.
area. So that would be in all of the charters, so it would be very clear that they were not a
Before they
decision
sign
maker before they sign up. Exactly.
So I didn't see anybody's hand raised, of kind of trying to come up with a more explicit strategy, is that accurate? We're gonna use our current board decision-making strategy, but we will spell it out more clearly in each of the charters so that people know that. That worked, okay, excellent. So with that in mind, are we in agreement that the draft committee, that the committee charters as they stand are a good draft moving forward? We'll make those, adjustments, and that those will be what we would use to launch these committees. Fist to five, you're in agreement for that? We got five, we got five, four, five, great. So everyone's either a 4 or a 5 on that, excellent. Now the fun part. Who would like to be on them? So let's start with the community engagement, committee. Do we have volunteer board members to be on that committee? We have Amy Fellows, Michelle Glass. Anyone else volunteering for that committee? Great, and for the Finance and Revenue Committee, do we have volunteers for that? We have Warren George, we have Cheryl Ramirez. Anyone else? You can be on more than one, just to clarify. And then the plan design and expenditures, I'll volunteer for that. We have Deborah Diaz, Cheryl Ramirez, and Warren George. Are you good, Katie? You got this?
Almost.
Okay.
Yes.
And then the operations committee. We have Bruce Goldberg. Hoping for at least one more.
I'm sure I see Judy's hand raised.
And I have agreed to do I'm happy to chair the operations committee. With the caveat that I'll work on the operations work stream, but that there'll be another board member that will chair the transition work stream.
Okay. I will talk to Judy and see what her interests are, because she's the only one not here. And then we will, but so far, I think everyone else is already on it. Right? Okay, and then we'll see what Judy's interests are, and then we'll work on at least one more board member for the operations committee, and we'll see how that goes.
And that one's starting just a little bit later, right? So
Yes.
there's a little bit more time.
It's a little bit of delay, it'll probably start early fall. Finance and engagement are the ones that start quickly, but yeah. Great, yay. Any other questions, comments on that? And we have no public comment. Great, so we have our final adjourning quotes. Deborah Diaz, you want to read it for us?
Sure, if we can really understand the problem, the answer will come out of it, because the answer is not separate from the problem. By G.B. Krishnamurti and the his work like that on learning through research.
Excellent. Thank you all so much for attending. Really appreciate your input. A lot of good work today. Thank you very much. And we will see you in July.
Can I have a
Oh,
quick,
yes.
quick request? This is one of the rare opportunity I get to be here in person.
Yes.
At work, photographer, can we have a good picture?
Oh, yes.
With the member and staff.
Wow. But the meeting's officially adjourned. Yeah, pictures. Thank you. Oh,
Right here? Oh, okay. Let me hide my garbage.
You're missing Michelle.
Oh, everywhere.
First.
Oh,
Okay, but yeah, Michelle is on the.
oh.
She just wanted to tell